Today I'm going to be talking to you about the importance of ensuring that antimicrobial stewardship principles are embedded into your local sepsis pathways. I'm Karen Thursky. I'm an infectious diseases physician in Melbourne, Australia, and I have had a 20-year history of implementing antimicrobial stewardship in sepsis pathways. So why is it so important that we need to reconcile sepsis and AMS initiatives? Well, both are global challenges that will be associated with millions of deaths each year. The emerging crisis of antimicrobial resistance will lead to many infections that will be untreatable and will impact on our ability to deliver cancer treatment and surgery, for example. But this lecture is not going to be around bugs and drugs, but rather I'm going to ask you to consider the systems approach that will be required to address this issue. This graphic highlights the real challenge that clinicians face in the setting of sepsis and septic shock. Clinicians, of course, need to make decisions and act before diagnostics are available. Timing is absolutely key. The future risk of AMR is somewhat abstract in this acute setting, and this may lead to complacency about the issue, which may lead to overdiagnosis and overtreatment with prolonged broad-spectrum antimicrobials. The other issue is that sepsis and AMS programs are typically separated in hospitals. Antimicrobial stewardship programs are a core requirement of national AMR plans, and they are really required to ensure the judicious use of antimicrobials, not just in hospitals, but across the healthcare and animal sectors. AMS is best considered as a patient safety issue first and foremost. Antimicrobials are the second most commonly prescribed drugs in hospitals, and these programs are often centred around inpatient wards, less commonly in ambulatory care and sometimes in ED, but there are fundamental components that are common to AMS across all these areas. And this requires the fact that there needs to be policies and procedures, top-level governance, leadership and accountability for delivery of these programs. Data to inform action is essential, and this might include both quantitative data as well as qualitative data about prescribing, procedures, for example. And the action requires the introduction of tools such as clinical pathways, decision support, electronic prescribing, human resources in particular to support antimicrobial stewardship teams, to support it and feedback. And then, of course, finally, that we need to continually build the evidence-based practice to undertake effective implementation and cost-effective care. On the right-hand side is what I call a knowledge translation cycle, and really understanding how we use data to create knowledge and how we use knowledge to change practice and how practice can improve quality of care. So starting from the red, if we consider a learning health systems approach for sepsis and infect stewardship, we need to ensure that in our organisation we are collecting appropriate data from clinical encounters, including electronic medical record data or administrative data, using this data to understand the patterns of prescribing and management of sepsis, benchmarking, for example, if there are multiple areas within a hospital or between hospitals and a network, and using this data to inform practice change through the development of clinical pathways, guidelines, decision support, for example. It's really important that we make the effort to evaluate the outcomes of our sepsis programs. It's not often done, but cost effectiveness is important, as well as understanding the appropriateness of management. And then, of course, the behaviour change required to drive, that is required to improve care and requires dedicated programs of effective communication and feedback. In the centre is what we call the learning health community, and this is really the community that you will use to drive your implementation, including infectious diseases, stewardship, ED, ICU, nursing, pharmacy, and administrative and managerial staff that will help build out your sepsis pathway and stewardship programs. How do we embed AMS principles in sepsis? Well, let's break it down. First of all, there is the recognition or the diagnostic considerations of a patient presenting to a hospital. And the question that's sometimes forgotten in all of this is that you need to have a suspected or known infection a priori before you apply the clinical rules. And in this situation, it's the single most important question. If that is the case, then it's really important that the appropriate diagnostics are done. And in sepsis, that is the sufficient quantity of blood as blood cultures prior to the administration of systemic antimicrobials to ensure optimal diagnostics, identification of a pathogen, and allows rationalisation of antimicrobial treatment. Secondly, in terms of the resuscitation, and it's not just about antimicrobials, which I often say, it's also about the fluid resuscitation, but in this situation, we're talking about ensuring that all prescribers have access to empiric guidelines which are stratified by presence or absence of allergy, severity of infection, include where possible dosing and even in administration information to support nursing staff. Most hospitals should have a formulary and or approvals and restriction process to ensure that drugs such as meropenem aren't empirically used unnecessarily. And then, of course, the timing, which I'll discuss later. The next component is to ensure rapid escalation as required, and this includes early RC review in the setting of severe sepsis and septic shock, source control, and early referral to infectious diseases. We do know that in some infections, such as staph bacteremia and candidemia, there is reduced mortality associated with early infectious diseases involvement. And finally, the management of a sepsis patient is not just about that first 6 to 12 hours in the ED. They have complex needs throughout their admission, including post-acute issues that require multidisciplinary attention. From a stewardship point of view, there is, of course, opportunities to review antimicrobials once the microbiology has returned, as well as switching to orals and providing appropriate patient and carer information and post-discharge planning. This publication on the left is a cancer whole-of-hospital pathway that was developed at Peter MacCallum Centre, and this was a co-designed pathway, and it is an open-source publication, and you can have a look at the actual pathway and implementation that was undertaken. But fundamentally, this was an AMS-led program of work. It was scaled from a cancer hospital to the Royal Melbourne Hospital, which is a large principal referral hospital, and then to 23 other rural and regional and other metropolitan hospitals across Victoria as a Think Sepsis Act Fast collaboration. In the Think Sepsis Act Fast collaboration, we were able to collect data from patients at similar time points during the year across 4 months in each health service, and demonstrated that the pathway was associated with a 6 times return on investment, but led to significant number of lives saved, ICU admissions, and reduced length of stay in just over a 4-month period. The pathway and the program recognises that you need to have structural measures in place as well as process measures to lead to improved outcomes. In the case of sepsis pathways, there are a number of elements that I think should be included in all sepsis programs, and these include early warning criteria, and I'm not going to go through all of those, but obviously there are SIRS, NEWS, MUSE, TRUES, and various other examples in the literature, as well as severity criteria to ensure that there's early escalation of patients at risk for poor outcome. There are many ways to introduce a sepsis pathway, but they can include either paper or electronic clinical pathways, order sets and bundles. I believe that nurse initiation is one of the most important success factors of the Think Sepsis pathway, which allowed nurses to initiate the pathway, including cannulation and undertaking all the bloods, oxygen, etc., to prepare the patient for early medical review, including empiric guidelines, making sure that it is a medical record rather than a piece of paper that stays in ED, and implementing what we would call a sepsis team to review the patient during the inpatient stay. Process measures are clearly common elements of most of the sepsis bundles that you will see, including the surviving sepsis. But I include appropriate antimicrobial choice, which is actually really important. And these are the type of outcome measures that you would consider if you were going to be implementing a pathway in your hospital. This slide shows the front page of the Think Sepsis Act Fast pathway, but essentially just to highlight some of the AMS principles that are embedded within it are the inclusion of the clinical criteria, the fact that the empiric guidelines are embedded, that there is detailed drug administration for particularly the aminoglycosides and vancomycin, that the tool was documented, was a medical record document that followed the patient from the emergency through their hospital admission and remained in the medical records as a tool to support the medical coders, diagnostic stewardship, approval request after the first dose, and then early referral and, of course, consideration of those patients who are under advanced care plans or goals of care. And then finally, to monitor and survey these patients. The pathway in its paper form was included all the elements that we described, and this has now been translated into an electronic clinical sepsis pathway in my precinct in both the EPIC and Cerner sites. The full methodology and evaluation of the Think Sepsis pathway are available on the links shown below and include the toolkit for your interest. What happened to antimicrobial prescribing when the pathway was implemented? You can see in this graph where you have the pathway launched, and this was a baseline prescribing prior to that, you see an immediate rise in piperacillin and tazobactam. In the first version of the cancer sepsis pathway, of which this graph refers to, piperacillin and tazobactam was the key antimicrobial in the pathway itself, and the second version included empiric guidelines that broadened out recommendations based on suspected or known infection site, which led to a decrease in use of other agents. But what I wanted to highlight is really a core AMS objective here, and that is to reduce the unnecessary use of broad-spectrum carbapenems and vancomycin, and this has certainly remained low ever since we've implemented and sustained that pathway. And so really a good clinical pathway will actually influence patterns of prescribing throughout the hospital admission and reduce to changes in volume of use. Let's look at the Surviving Sepsis campaign. You can see that there are a couple of elements of antimicrobial stewardship that have been included in terms of some of the early steps, including blood cultures prior to administering antimicrobials and the recommendation to use broad-spectrum antimicrobials. However, the real issue is that this is probably not sufficient. So let's look at emergency department antimicrobial stewardship. And this is important because we know that over 90% of patients with sepsis will present through the emergency. And this was a fantastic piece of work, which was a consensus process using the Delphi methodology, using stakeholders from multiple specialties, from ED, microbiology, infectious diseases, who worked together to establish a set of quality indicators. They're predominantly European-based to support AMS in the ED. They are a comprehensive suite of quality indicators, and in toto would constitute the basis of an AMS program. There was another very nice study that examined a handful of these indicators in the emergency department, 7 I think they used, and you can see that 100% adherence was associated with a reduction in in-hospital mortality. So coming back to timing of antimicrobials, this has been one of the most contentious issues that has been extensively analysed and debated over the years. I was really happy to find this fantastic paper that took a really deep dive into data from all the studies, and fundamentally we need to consider that there really are very many sources of bias in looking at sepsis studies. When we look at antimicrobial timing, in many of the studies undertaken, sepsis and septic shock were grouped, and they're obviously not the same. The other issue is around time zero, which can be measured in many different ways, and there still remains no gold standard. And there's also been an assumption that the change in mortality is linear, and this is simply not true. And finally, many of the studies didn't account for multiple comorbidities, and one of the issues that I think is key is that we often don't know the quality of resuscitation at initial presentation. So a summary really are that there is a strong association with timing of antimicrobials and septic shock, and that in the absence of septic shock, there is a sharp increase in mortality after the first 3 to 5 hours. So this is very well reflected in the antimicrobial recommendations in the Surviving Sepsis campaign that you can see in front of you. There is no question that if sepsis is definite or probable, then antimicrobials should be administered immediately, ideally within an hour. If it is unclear whether there is sepsis and in fact if infection is uncertain, that it may be a non-infectious cause, then there's certainly room for investigation and administration of antimicrobials within 3 hours. And I think that's a really nice way to meet the evidence that I think has been emerging over recent years. So this is my last slide, and it's really about aligning sepsis and AMS initiatives. It is really important that you take a whole of system approach, that it is a multidisciplinary one, and bring together stewardship, ICU, ED, nursing, pharmacy, ID, the lab, and health services researchers to ensure that you can measure and to evaluate your programs, to work on aligning your process and outcome measures. And finally, and I can't stress this enough, you do need to have dedicated planning and dedicated resources to execute a well-implemented program. Good luck, and thank you for listening.